Welcome to the Gyne Awareness Podcast, real talk to understanding gynecologic conditions and care. The goal of this podcast is to bring you clear, evidence-based medical information by experts in the field of gynecology to help empower you in your health journey. Participants on this podcast are healthcare professionals, specialists and advocates in the field of minimally invasive gynecologic surgery. The views and opinions shared in this podcast are those of the speakers and do not necessarily reflect the official policy of AAGL. This content is provided for general educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Listeners should always seek the guidance of a qualified healthcare provider with any questions about their own health. If you are experiencing a medical emergency, call 911 or your local emergency number immediately.
Okay, everyone. I'm so, after hearing all about the different diagnostic options for patients with endometriosis, let's talk about what happens when you actually suspect a patient has endometriosis. What are our treatment options? Shanti, you want to start us off?
Absolutely. So the things that would make me say, yeah, I think you need to have surgery are going to be a constellation, right? So you have these terrible, painful symptoms. They are now not just with the period, but throughout the month. They're now like both sides of the pelvis, maybe pain in the hips, down the leg. And then your exam suggests maybe some extreme pain behind the cervix when I do your exam. And you've got a family history, and I'm thinking, wow, this is a likely patient who's going to have endometriosis. So you asked me what I would do. I usually go straight to surgery. And this may be very different from other physicians or surgeons, but because patients are coming to me usually after they've tried the pill, they've tried the Mirena IUD, they've tried maybe another medication that makes you almost menopausal, and they still have this persistent pain or side effects from all those other attempts at controlling their pain. So in my case, usually they're coming because they want surgery. And so we'll start diagnostically and look, but I think Cara has coined this see and treat kind of concept where I'm absolutely going to treat at the same time. And in my practice, treatment means excising all the disease. And that might mean removing a cyst from an ovary. That might mean carving disease off a pelvic sidewall. And maybe it even means getting it off of the bowel. Sometimes it might even be a bowel resection. Sometimes we see it going all the way into the bowel or onto the diaphragm. So these surgeries can be straightforward with mild disease, and they can be complex and extreme when you have advanced disease. So that would be the first line treatment. And I think later we could get into some other things that I recommend for patients after surgery and ways that they can improve their lives moving forward. But the first thing for me is to excise that disease, and usually sparing the ovaries and sparing the uterus when we can. Many patients want to preserve their fertility. Sometimes they don't, and we have that conversation and proceed. But a lot of the time we want to save those organs.
I absolutely, it sounds like you have a highly consultative practice. Patients have been like looking and looking and looking for you, Shanti, but I can imagine we have some patients listening that say, oh my goodness, I'm not ready for surgery. Like, do they have to have surgery for us to diagnose endometriosis? Cara, what do you think?
It's a great question. And I think this is one of my favorite parts of my practice, other than excising endo. That's like by far my favorite. But second place is going to be the discussion around every patient's journey. Like every treatment plan that we create is unique. I truly mean that, because everybody walks in with a different set of experiences and a different set of pain symptoms and a different set of priorities, meaning reproductive health versus pain versus where they are with school or work or childcare or, a million things. And so I think one part of my practice that I really genuinely love is understanding patients' priorities, what they're coming in with, what they've tried before, and then scaffolding options, right? So when I meet with my patients, I oftentimes break things up into three buckets when I can. And what those buckets are expectant management, medical suppression, or surgical intervention. And sometimes they don't have all those options, meaning sometimes someone comes in with a bowel obstruction, like that we need to treat surgically quite urgently. But in general, if there are no red flags of acute, like need to go back right now, then expectant management can sometimes feel good to a patient in that they can figure out things at home before they proceed. From a medical suppression standpoint, that can be typically hormonal suppression. I wish we had more options. I'm with Sony on this research endeavor that we need to do more research into this disease process to be able to offer non-hormonal options, but we can break down hormonal suppression options next. But oftentimes that can be an option depending on what they prioritize in regard to fertility. If pregnancy is a priority, then those are obviously not options. Or if they have tried hormonal suppression and they have no pain relief within 3 months, then oftentimes we'll move forward, but that can sometimes be an option. And then surgical intervention. And Shanti explained that perfectly, right? So from a surgical perspective, that's typically laparoscopic, so small incisions. And I'm very lucky at my institution that we have a very deep and robust multidisciplinary team. So I want the right location with the right surgeon and the right surgery all at once. And so what that means is that we are going in laparoscopically with whatever other teammates that we need and doing full excision, as we mentioned, if it's the right thing as we balance reproductive health. And that may include fertility sparing if that's their priority, or that may include a hysterectomy if that's their priority, right? But I think understanding your patient's journey and their priorities really helps tailor the treatment options. Sony, what did I miss?
No, I think this is great. And I think we have a very similar approach to really getting guidance from the patient themselves. The only other things I would say is that there are, these are still people who have other goals. So contraception comes up. And I think about my daughter. I hope she's not watching this right now because we've talked about this. But, contraception might come up. And although, there may be pain because of endometriosis or pain because it's not known yet, but there might be other needs for care. So, the birth control pill is still an effective contraceptive. So is the progestin IUS, and it may help with pain as well, especially in those who aren't ready to have surgery, are contemplating what their options are. So I do think the way I look at it is to look at the whole patient. There are also values. There are cultural values, individual values that might say, you know what, I don't want any hormonal therapy. So there are some non-hormonal therapies which aren't specific to endometriosis, but they manage pain. So anti-inflammatories do help with painful periods, but we got to be careful. We mentioned this earlier that it can hurt the stomach or the kidneys if taken in excess. So we have to balance and be careful with that. There's something called tranexamic acid, which is great for heavy bleeding. So there are non-hormonal medications. And then finally, what I also do, we have a little tree that I can give to all our learners to counsel patients. And it starts with, lifestyle modification. So it's all about making sure you get enough exercise, what your healthy eating habits, getting enough sleep. That and pain, they do not go well together. So people who don't get great sleep, including myself, we have more pain. And then there's complementary therapies, so pelvic physiotherapy for that, pelvic floor issues that they may have. Sometimes it might be beneficial to see a dietitian or a naturopath as well. And then I look at all the different medical ones, which Cara's beautifully gone over. And then finally, surgery. And within my surgery toolbox includes nerve injections and pain management in other ways. But the one final thing that makes a big difference in pain is education. We do know that once we explain where pain is coming from, if people get an idea and the understanding, that in and of itself is empowering, because then you have something you can deal with. And one of the things that I do tell patients is we don't stop. So if the first approach didn't work, we'll continue along the journey with another approach, but we'll keep helping you. And that's why it's a lifelong journey and a lifelong plan to make sure we meet their goals.
I want to just chime in here because I absolutely love what the two of you have just said. That comes together with number one, communication, listening, hearing what's going on, and and then we are trying to help put it together. And then having a multidisciplinary, meaning multiple different ways that we can try and work with pain. So beautifully said by both of you. And it just like communication, education, and what do you as a patient want? Do you never want to have a period again in your life? Or do you want to preserve it and just feel better? And so how can we help to make that happen? And I hear both you too so beautifully describing that process. And I think if you feel like you're not being heard by your surgeon or your physician, that you want to find someone who will really listen and give you options and try to find answers, right?
100%, Shanti. I 100% agree with you guys. This is like, I love to hear the way you guys think through how you really counsel patients, how you go about figuring out the disease. Often for patients who have sort of been stuck in this cycle with various physicians of not getting answers, right? Okay, I'm going to bring up something sometimes controversial. I don't think it will be on this group, but all over social media, people say, are you an excision surgeon or are you an ablation surgeon? And I'm an excision surgeon. I think Shanti is too. I think that's what you said. I'd love to hear from everybody. What does that mean, excision versus ablation for patients?
I'll let Cara go ahead of me because I think we've got two self-disclosed excisionists. Yeah.
Yeah, I love this question too. Yeah, so I am also an excision surgeon, 100%. And there's a lot of reasons why, and I would assume this entire panel agrees, in that number one, it allows you to get pathology, right? So some things you may think are endo and are not. Some things don't look like endo and they are. And if we're going to give somebody the endometriosis diagnosis, that's serious. Like you want to make sure someone has that if truly they do. Two, it allows you to remove disease over structures that you wouldn't be able to ablate over, such as ureter, bowel, bladder, right? So it allows full excision. And it also allows you to get to the entire base of the disease. So a lot of times we'll talk about the iceberg effect, where you can't quite tell how deep it goes until you start excising. So if you just ablate means burn, and you can burn with a lot of different ways, bipolar or monopolar or laser or plasma jet, but basically you're just kind of burning the tissue on the top. But if you do that, you may be leaving all that deep disease below. So if you have really accurate imaging, that can sometimes tip it off. Ultrasound or MRI can tip it off. But that full excision allows you to get to all the way down to the base and remove the entire nodule. So I'm definitely an excision surgeon. Sony, how about you?
So here's the big secret. This is not a thing. You can't like I don't understand what other alternative there is.
Oh, I was like, what?
Either,
What are we
no,
doing?
we're on the same page. The point is, it's unfortunate that we got to a point where we had to explain who's an excision surgeon versus not. So it's basically who's an endometriosis surgeon and who's not an endometriosis surgeon. And I think general OBGYNs, when we got trained, we do a good job of diagnosing, I hope, and being able to manage things. But to manage complex endometriosis care, there is no other option. You can't burn this disease that we see. And when, the problem on this panel is that we have fantastic surgeons who are dealing with complex disease. And it is important to recognize that you may have surgery with someone who doesn't have as much experience, but that's okay because I have lots of friends like that. But as long as they know to identify and refer on, and ideally not burn anything, even just take pictures and get the information and send them on. So that's the big secret. It's endometriosis surgeons need to excise disease to give that full therapy and diagnosis at the same time that Cara's gone over. And I think that's it. One other aspect is it's not okay just to be what we call an excision surgeon or an endometriosis surgeon. For complex disease, it requires a team. It requires a team who can manage pain. It requires a team who can manage bowel, bladder, diaphragm, and there's even fewer of those individuals. So I think when we have colleagues who we work with who do excision, we also need to have colleagues who do excision who know when to refer when it is more complex and you require a whole team. And that team approach is very uncommon still, and that's what we have to fight for.
I mean, speaking of that team approach and the few centers that we're sort of describing, I think we're all lucky to work in big teams to do this type of work. But what do patients do if they're not in a place with teams of people doing this? Shanti, in your part of the country, what do you see?
Well, that's a great question. Sometimes I do free consultations on Zoom with patients who are thinking about traveling or not, and maybe they can't afford it, which is one of the really difficult parts about endometriosis and insurance coverage. So I recommend, if they truly can't travel at this point in their time, to get someone who would excise it, that they at least get a clear diagnosis and really ask someone to take a look, maybe just at 2 tiny cuts, and really take photographs. And I think we have a European model for this, where outlying, more rural physicians make a diagnosis. They do photographs, they look up and down, they look at the diaphragm, they look all over, and then they refer to some center where they have a multidisciplinary team. And when we say that multidisciplinary team, we mean someone who could treat it on the bowel, someone who could go into the pulmonary lung cavity, for example, and into in urologic disease. That means like the kidney tubes to the bladder, right? So we do only have a limited number of these specialty kind of programs. So if that's not accessible, at least really truly getting a diagnosis, and that can sometimes be surgical, to fully understand what's going on, might be the answer. That then at least they could get a referral because their doctor wouldn't be able to treat the bowel disease, for example. So getting I didn't mean to be so long-winded, really just getting that clear diagnosis so they at least know what's going on, and then they can move forward with, okay, medical treatment first, until I can get some better treatment, and so forth.
Cara, I'd love for you to expand a little bit on that in your part of the country. You guys are on opposite ends of the country. I'm right in the middle of the both of you. So what do you see, in Cleveland and on the East Coast?
Yeah, I love this. I love seeing how everyone else is managing this, because I learned from all of my teammates as well. One pro tip that I don't want to forget to mention, which you've all kind of mentioned, is that for patients, when you see a physician, if you can bring your operative notes and pathology notes, that is so helpful for us. And if you have surgical images, that is like gold. Like when my patient comes in with surgical images, I just feel the greatest joy, and that I can really see what has been done. So pro tip for patients, bring us op notes, path notes, and surgical images. That's going to be excessively helpful. So in regard to what I'm doing here at the Cleveland Clinic, again, I am really lucky in that we have a lot of resources here. And what that means is we have an entire group of nurse coordinators. I have a group of 4 nurse practitioners, and then my group. And so really what we try to do is evaluate every patient that has a consult before they get here, go through their record. And so that when people make the trip in here, we have everything lined up. If we review their images and pathology and op notes beforehand and think they need additional imaging, we have that lined up when they get here. If we think they need a colorectal consult or urology consult, we try to have that lined up when they get here. And so we understand that a lot of our patients are traveling out of state or out of country. And so we really want to optimize the time that they're in Cleveland, despite it is a beautiful city right on Lake Erie. You don't want to spend more time here than you have to, that we have it all lined up. And we also have something called a second opinion or second consult. And so if you do not have insurance for Cleveland Clinic, we also offer a service, or similar to what Shanti just mentioned, that we will actually review your records and help give recommendations before you potentially make the trip out to see us. Because again, we value your time. And so we have an entire group looking at your history, so we can align everything up during your stay for hopefully all the things that you would require.
Yeah. Sony, I'd love to hear what sort of happens in Canada, because it's a very different healthcare system there. So patients who are listening all over, what do they do in Canada?
So it is a universal healthcare system where private doctors essentially, but in a public system where we have one insurer. That's the easiest way to understand it. The government covers everybody. So the nice thing is that when you have care, you can be rich or poor, you will get great care. And I can attest to that when we need that interdisciplinary approach, I don't know how much money that person has made, what kind of insurance they need to have. It's all covered. However, that means that there's long queues to get in because we don't have enough places to provide that care. So there is no private setup in our country. So access to care is really based on long wait lists. So a lot of our patients, and we just finished a study, we're analyzing the results of patients who are leaving the country to access care and why are they needing to get care and where are they having to go. I know both of my colleagues here have probably seen Canadian patients because of that long wait, and you've probably as well. So, that's part of the problem. But at the same time, I've had the privilege to operate in the Arctic above the tree line on patients who are Inuit, who have struggled for years without a diagnosis, and we've treated their endometriosis. I've gone to rural Canada. I've operated regularly in a small place about 4 or 5 hours away where we set up the cases and organize things. So for me, I think not just in Canada, but globally, we need to better organize how to get patients to care, irrespective of their background or their financial circumstances. And what I've learned is that a lot of the high profile surgery we hear about is done in private surgical centers. So I think it's important as women's health advocates that we recognize that that inequity is a troubling aspect. And I hope that we can aim towards greater access for everyone. So whether that means that surgeons like myself, I've enjoyed traveling to these communities, or we get patients in like Cara's program or Shanti's program where you can get a second opinion, at least to get some advice. And so I think that is going to be our next battle, is how do we get more people access, understanding can't be perfect, but we can at least try.
Thank you guys all for sharing sort of your stories about different areas of the country and the different patients that you see that are coming to you for this diagnosis.
Thank you for listening today. We hope you enjoyed this podcast. To listen to other podcast sessions, visit us at gynawareness.com. You can also follow or subscribe to the Gynawareness podcast on Spotify or Apple Music.